Welcome back to the second morning session of the annual Kingston Research Conference, and we've now been joined by three further plenary speakers. And just to I know that some of you have been with us for the whole session, and thank you very much for that engagement. Others of you are in different time scales, so you've come to us a little bit later. So very much welcome to a new group of speakers, and the arrangements that we have are that we're just going to ask you to speak for your 20 minutes or so, and then there'll be a discussion afterwards, and you'll be able to see some of the points that will come up in the discussion in the chat column on your screen if you have that up. But Rick will take us through it when we get to that point. So again, can I say welcome to our three new speakers. Thanks very much to the three plenary speakers from the first session for starting us off so well. And now we have, first of all, Dr. Rachelle Ashcroft from the University of Toronto to talk to us about some of the interprofessional implications of working in COVID-19, which have been raised for us. But I think this is a really important focus for us to take up. Rachelle.
Thank you so much for having me here today. I am so pleased to be here with you and share some of what I've learned about interprofessional primary care during COVID-19. First, I just want to note that the work that I'm presenting today is being done with a robust team of collaborators, including patient partners. So what I'm presenting today is not an individual endeavor. Second, I do want to take this opportunity to thank Professor Payne for his work that has deeply inspired how I approach my own scholarship of social work and understanding social work within healthcare context, and was very excited to have this opportunity to meet Professor Payne today. So at 7 o'clock, it's just after 7 o'clock in the morning where I am. I'm joining you from Toronto, Ontario, which is illustrated on these maps by the two red arrows in the bottom portion of my slide. So Canada has a population of just over 38 million people, and it's comprised of 10 provinces, with Ontario being one of them, and 3 territories. So just want to give you a sense of the diversity of our country in terms of just the geographical nature. Throughout the pandemic, there have been different rates of COVID-19 and different strategies used across Canada's geographical regions. This slide depicts the most current total case counts of COVID-19, which were current as of 2 days ago when I created this slide. And the majority of my research, however, in interprofessional primary care is largely situated in Ontario, which is where I'm residing. So that's the map on the right-hand side. That is the map of Ontario, which in itself is also quite a large geographical region. So Ontario has a population of over 14 million and is the province in Canada that has had the largest total case counts of COVID-19 in the country. Just to kind of give you context, as the context of the teams which I'm going to be talking about. The teams, the interprofessional teams and the primary care teams that I will be speaking about are located across the geographical regions of Ontario, so from north to south, from east to west. Interprofessional primary care teams are comprised of various types of healthcare professionals, which include family physicians, nurses, social workers, pharmacists, physiotherapists, dietitians, and others. Not all teams that I'm speaking about have the same configuration in terms of the types and amounts of the different healthcare providers, but what determines the configuration and the amounts of these different healthcare providers, including social work, is in relation most often to patient care needs, which is important to think about as we've seen changes over COVID-19, and as well as community needs. Ontario has been a leader in the expansion of interprofessional primary care with 2 key models. So the first being the community health centers, which originally emerged in the early 70s, and family health teams, which emerged in mid-2000s during a period of primary care reform. And these interprofessional team-based models of primary care are integral for access in Ontario to comprehensive community-based whole person care, which aligns with social work's biopsychosocial approach. And in Ontario, social workers are now the third largest group of professionals in these primary care teams. So it is quite an important model of healthcare for social work and social work's contributions to healthcare. So third largest group of professionals following physicians and nurses. It's also important to note that health and mental health services in primary care is publicly funded, and these teams have significantly facilitated access to social work services for many patients and communities who may not otherwise have had access to social work services. Insights I'm going to share come from a combination of these 5 studies that I have and with the virtual care study continue to conduct since the start of the COVID-19 pandemic. So these studies are a mix of survey and qualitative methods. These 5 studies have sought to understand the impact of COVID-19 on the delivery of patient care from the perspectives of a range of interprofessional providers, which include social workers, executive directors, primary care teams, and patients themselves. On the right-hand side of the slide, a couple examples of the publications that have come out of this research, and we do have some papers that are currently under review as well. So coming here today, there's so much change that has happened in primary care. It was difficult to narrow down to 2 key topics, but what I've decided to talk about are the 2 biggest changes that we've seen in interprofessional primary care during COVID-19. First, the changes in the types of patient care, and second, changes in how patient care is being delivered, so virtual care. We heard a little bit about that in different contexts earlier in the session, and it certainly is the case for primary care. So early in the pandemic, my team and I, we asked interprofessional providers about the top conditions that brought patients to see them prior to COVID-19 and after the onset of COVID-19. So we saw a shift occur with the type of care provided in primary care, especially in the earlier waves of the pandemic. Patients were receiving less prevention care, and there was a decrease in ongoing comprehensive care for various chronic conditions like diabetes. Instead, we actually saw more of a focus on acute issues, which is illustrated by the items circled on the bar graph. And one of the reasons is we've learned anecdotally that we were in lockdown, and some patients just chose not to seek care for things that they didn't deem to be emergent. So there was a delay in receiving some of those preventative cares. So that was a change that we saw. The second change that we've seen during the pandemic is an increase in patients reaching out to primary care for reasons related to mental health and addictions, geriatric health needs, food insecurity, social isolation, and wanting help getting connected to other community resources, which actually was quite challenging during Ontario in the first wave in particular, or the first 2 waves where many of our community organizations shut down during that period. And so, which again, you can see illustrated by these items circled on the bar graph. And I know there's a lot going on the slide, but it's just really to illustrate some of the changes that we've seen pre-COVID versus post-COVID. Early in the pandemic as well, social workers and nurses proactively were able to reach out to patients in the form of doing wellness checks. Many of these teams have electronic medical records, which enable them to quickly create lists of patients in the community that they deem to be at risk for one reason or another, and do proactive phone calls to reach out to those patients to determine what types of services that they may benefit from, and just to make sure that they were managing okay given the isolation of the pandemic. It may not come as a surprise to you that across all of our studies, what we've learned about is the overwhelming high demands for mental health care, more referrals to social workers and mental health counselors because of these different social determinants of health related reasons, mental health crisis, including increased suicidality, And we also learned about some communities facing increased rates of overdoses and higher rates of addictions. This is really important for us to take note of because there were long wait lists for social workers in these teams and mental health services even prior to COVID-19. So as we've seen this demand increase, we've also seen quite a dramatic demand increase for social work services. The second significant change we saw in Ontario was related to how care occurs in these teams, with the robust uptake of virtual care. And so when I'm using the term virtual care today, what I'm primarily referring to is a combination of telephone and video appointments. So 2 years ago, on March 17th, 2020, Ontario declared a state of emergency. Before March 2020, 99% of all care within these teams was done in person. Because of the need to physically distance, there's a dramatic uptake of virtual care in the form of these telephone and video appointments. And that included telephone and video appointments that were had with family physicians, nurses, social workers, physiotherapists, occupational therapists, the whole wide range of providers in these teams. Some in-person care continued, but the vast majority of care occurred, shifted to virtual appointments. And these virtual appointments continue to this day. This has been a dramatic and significant shift here in Ontario. The rapid shift to using virtual methods for patient care was very new for the vast majority of providers in these teams. Most providers, including the social workers that we've spoken to, hadn't been trained in doing assessments and treatments via telephone and video. And the other aspect that was quite challenging was even getting access to technology. So working from home, having access to the electronic medical records, for our northern communities, also having access to adequate high-speed internet was quite challenging. So we also wanted to know during this rapid shift what patients' experiences were with this new form of virtual care. Patients we surveyed and interviewed had virtual appointments for a broad range of reasons since COVID-19. So urgent and acute issues, chronic related reasons, mental health care, different types of preventative care, the whole gamut. And surprisingly, patients told us that they had very positive experience with virtual care. And I have to say, as somebody who's doing interviews with patients, I was actually quite surprised at how positive patients reported these virtual care appointments. We did the survey and the interviews with patients in January 2021. So we did have a year after the start of the pandemic. So there was, there was a period where patients and providers had adapted by the time that we did this particular study. So what we heard when we interviewed patients is that virtual care was very new for them, and patients see that it's also very new for their providers. However, patients told us that they did have some benefits of doing appointments by telephone or video. It's more accessible financially. It's more accessible with the vast geography. Patients didn't have to drive long distances. It's convenient, flexible. Having an existing relationship with a family physician, nurse, or social work, not surprising, made it easier for patients to transition to virtual appointments. And in our survey data, we actually saw that patients who had a relationship of 1 year or greater actually had better experiences with these virtual care appointments. Patients also liked that it was much easier to include family and significant others, as well as interpreters during these appointments. So it wasn't difficult to have a three-way telephone call or to have a Zoom meeting with your family physician and another family member in a different geographical location. So there were some benefits that patients talked about. Patients did caution us, however, as we're thinking about the long-term use of virtual care in these settings. Patients cautioned us that telephone and video appointments may not be suitable for certain aspects of mental health care. And we're currently doing some additional research to determine what aspects of mental health care work well, what aspects don't work well virtually. Patients also cautioned us that the long-term use of virtual care may actually potentially erode that therapeutic relationship, which is one of those elements that makes primary care so good. and it's a key component of primary care. Another concern is that these virtual appointments are shorter and more problem-focused than in-person appointments, which means that patients will have potentially less opportunity to bring up other health concerns when meeting with a family physician or a nurse practitioner, like family issues, work and financial issues, mental health concerns, and the whole range of different issues that sometimes are the point of entry for a referral to social work or to engage social work in patient care. We asked, in terms of planning for the future, we asked patients across Ontario what they wanted for the future use of virtual care in these teams. And again, it surprised me that most patients want option for virtual care and are asking for virtual care to continue. However, what we've heard is that patients do not want a total replacement. So they want a combination of in-person as well as telephone and video appointments. There were a few patients that said they only wanted in-person, and there's a whole range of reasons that patients said they only want in-person, but there is a desire to have a combination of in-person, telephone, and video going forward. So currently my team and I are working on a continuation of this work to determine what specific types of appointments are most appropriate for telephone and video. So for example, we've heard, not surprising, that there are some challenges when there's a need to show a provider something behavioral or show a provider something that is physical, and was much more challenging for some of the providers in the team, like physiotherapists, who tend to do more hands-on type of care versus other providers who don't do that type of hands-on type of care. One of the robust challenges, however, that we've heard across our studies with the uptake of virtual care is related to how teams are collaborating during this time. Prior to the pandemic, collaboration relied largely on informal processes like hallway conversations. Consultations about different and difficult cases would happen in between appointments, in the hallway. Interactions would happen in the lunchroom. And as somebody who practiced in healthcare for a long time, that wasn't surprising to me to learn, because in my own practice experience, that was largely how I remember collaborating as well. That if you had a difficult case, you grabbed a physician, grabbed the dietitian, and had an impromptu conversation. However, virtual care has dramatically changed this. In our surveys and focus groups, providers described a change in the frequency of interactions they've had with their fellow teammates, and that they interact with fewer members and fewer variations of members on their team. This is particularly important because there were fewer case consultations at a time when patients were having even more complex mental health difficulties. And it's something that I'm thinking about in terms of the social work role, and how we know that visibility is very important for one of the non-medical members of these teams to be visible in order for other team members to understand what our role is. So fewer interactions. In addition, providers in these teams, including social workers, described feeling quite isolated. They were quite used to working within some of them referred to like the bullpen setting, where their teams are all sitting within the same office setting, are interacting quite regularly. And in some cases, what we've heard, this high level of isolation may actually be contributing to burnout in some cases. So it's quite an important element of shifting to virtual care that we need to think about. So what does this mean? Implications for teams and implications for social work. Well, implications for the teams going forward is, first, we have seen a shift in terms of the type of care needs, the dramatic increase in the need for mental health care. So the teams are currently trying to determine how best to do that. With virtual care, what we see that we going forward need in Ontario and elsewhere are more specific guidelines in terms of the type of care that are best suited for virtual appointments. We need training, support, and research across all the disciplines, as well as the collaborative team, to ensure that we are providing care that aligns well with virtual care. And again, patients want this to continue and want the option for virtual care to continue. We need to also determine if there is, whatever that configuration looks like in the future, whether it's a combination of in-person and virtual, determining what the team processes will be in order to support collaboration. And I do think that this is one area where social work could potentially provide some additional leadership. We've seen over the course of the last 2 years in these teams, there's been high demand for social work services. The concern is there's long wait lists currently for social work services, even longer than there was prior to COVID-19. There's a requirement, not just for the teams, but for us in social work to think about how we're training newly emerging social workers for this new context. And as somebody who trains now social workers, new social workers in Ontario, prior to COVID-19, we weren't doing training for this virtual care context. So it really is something new for us to consider. And within and beyond primary care, social work does have a role in providing leadership around social recovery from COVID-19. And currently, one of the new studies that I have emerging this month, as soon as we get our ethics clearance, is a survey that we're about to launch, a provincial-wide survey of social workers in primary care, followed by focus groups with social workers in primary care to understand more specifically what their experiences have been and what they envision to be social work's role kind of ongoing for the recovery of COVID-19 within these teams. And thank you. There's my email. Feel free, if this is a topic that interests you, to reach out and email you, and happy to answer questions after.
Thank you for that fantastic presentation. It was really interesting, and so many connections with the other things that we've been talking about. So I'd really like to move straight on to Professor Maureen Samms-Vaughan from the University of the West Indies. And again, another contribution, slightly different field this time, on child welfare in Jamaica, but affected by COVID-19. So over to you, Maureen.
Good morning, everyone. I am speaking to you from Kingston, Jamaica, and here it is morning time. It's minutes to 7 in the morning, and today I want to thank the presenters for inviting me to speak about Jamaica today, and to speak on the topic of child welfare in Jamaica during COVID-19. The social work community is a critical part of our child welfare system in Jamaica, and it's a privilege to be able to speak with you. Part of 9,700 children established in Jamaica in July to September 2011. We spoke with 547 households of the pandemic in April to June 2020. At the same time, UNICEF was doing a study, a stratified random sample of 505 households with at least one child, data collected just after the JA Kids study. But first, let's put COVID-19 in epidemiological perspective. As at the 15th of March, there were 458 million cases with just over 6 million deaths. The Caribbean finds us in the region of 50 to 500,000 deaths, a lighter blue than most of the world. In terms of Jamaica, we have had 128,400 cases and just under 3,000 deaths. And as you can see, we went through our waves much as the rest of the world did. When we look at what happens to children, which children are the focus of my presentation, the World Health Organization indicates that children are really not the main persons who get impacted by COVID in a direct way. So under 5 years, we have only 1.8% of cases. But as we get into the teenage adolescent years, we move up to about 14.5% of cases. When we talk about deaths, we move from 0.1% of deaths under 5 years to 0.4% of deaths in children 15 to 24 years, children and young adults. So what does this mean for children? It means that the primary health focus is necessarily now on older persons, and particularly those with chronic illnesses. Children are therefore not often at the front and center for health and other considerations, yet they're likely to be the most impacted for a number of reasons. Developmental reasons, because they're in the developmental phase of their life primarily. So let's look at all the impacts that occur with children. First, I wanted to talk about just briefly about the direct health impact. The most severe condition affecting children is called MIS-C, or multisystem inflammatory syndrome in children. It was actually first characterized in London in April 2020 when very ill children started being admitted to hospital. In the United States, they've had close to 7,000 cases with 48 deaths. The majority of deaths in the US occur in Hispanic, Latino, or Black children, and in the UK in Black, Asian, and other minority groups. Most of these children get exposed in their homes and their communities, and this is just indicating a possible racial disparity in healthcare. But the larger group of children get more impacted by indirect health impacts: their physical health, their nutrition, their sleep, their mental health. Well, let's talk about primary care health. There was reduced access to primary care facilities. This was also mentioned in our previous presentation, reduced health-seeking behavior. Parents had serious concerns about taking their children to healthcare facilities, not only at the facilities, but the process of getting them there using public transport. Some health facilities were closed as staff was redirected from primary care activities into secondary and tertiary level care. What this meant was that our immunization rates were reduced, and there was delayed identification of new acute and chronic childhood illnesses. And we're now seeing children coming to us with more severe illnesses than we would normally have seen. A similar thing happened at the secondary and tertiary care level. Again, parents were concerned about taking their children to hospitals. Staff was moved from pediatric services because adult services were so overwhelmed. So the second and tertiary care services, pediatricians were asked to work in adult care, something they had not done for many, many years. There was reallocation of pediatric wards to adult COVID-19 wards, and there was postponement of tertiary care services. What this meant, again, was the reduced services for pediatric acute and chronic care. In terms of nutrition, the picture on the right shows just before, if you see the date, that's the 21st of February 2020, when the government, was using their PR system to indicate that 100,000 children were now going to be put on the government of Jamaica's school feeding program, which is providing meals for children during school time, children in poverty. So this disrupted nutrition support for children. So the government supported school feeding programs meant that children were not getting the additional nutrition that would occur. Many schools outside of the government supported programs offer school supported breakfast programs. And so this was another loss to children. And then on a day-to-day basis, there's informal nutrition support at school. We all know when we send our children to school, that they're not necessarily the ones who eat their lunches. We actually don't know what happens in that eating process at school, but a lot of change takes place between who likes what and who has what in what lunch kit. And also, teachers often identify children who they support individually. And all of these supports were reduced. When we asked parents in our study how difficult it was for them to provide food for their children, you can see that even the home circumstances were impacted. So we had 22% of parents reporting that it was very difficult or somewhat difficult before the onset of COVID-19. By the time COVID-19 took place, and this was very, very early on, we were having almost 40% of parents reporting that. The UNICEF study identified that food insecurity had increased and was at 44%. And the households that were most affected were rural households, female-headed households, and households with more than one child. And these are the households that are most impacted in situations of poverty. So again, food insecurity was worsened. We asked parents how they coped with food shortages, and they reported in the majority, 3/4, that they made smaller meals. 2/3 reported that they did fewer meals because we have access to areas for agriculture. Some parents decided that they would plant some more crops, which of course was going to take a little time to reap the benefits. And some parents reported getting cheaper foods, which are largely high carbohydrate, starchy diets that we are trying to reduce in the country at this time. We did not have any studies about overnutrition, but certainly studies in other countries reported that overnutrition was a concern because of a lack of daily structure, changes in sleep routine, the length of quarantine, increased screen time, and decreased physical activity. We are now studying this because, you know, Jamaica had actually transitioned from a situation where undernutrition was the main concern. Overnutrition is now our main concern. And so this would have worsened. Children's sleep was impacted due to disruptions to their usual schedules, the absence of physical activity, excessive screen time, and increase in mental health disorders, which we're going to discuss in a minute. We did not have any particular studies of COVID-19 on sleep, but I work in a clinic with children with developmental disabilities, and for sure, parents were complaining about difficulties with children's sleep. But studies in preschoolers had suggested that during COVID-19, there was a decrease in adherence to bedtime routines, a decrease in the amount of sleep, and in sleep quality. And they reported a rapid decrease and then a stabilization to that new normal of decreased sleep, which now means that children would be having chronic sleep deprivation. A variety of factors were also reported to contribute to impaired mental health during COVID-19. There's the physical health, the length of isolation, the fear, the frustration and the boredom, the lack of contact with peers, bereavement as children lost family members, family difficulties, parental mental health, and pre-existing challenges with socioeconomic background and comorbid mental illness. We asked parents about their children's mental health conditions in these specific categories. 2/3 of parents reported their children being exceptionally bored. Here comes the obesity again. 57% reported that children tended to overeat. Increased frustration was noted in 41%, excessive clinginess in 39%. Actual features of anxiety and sadness were reported in 1/4 of children, and fears in 1/5. 15% of children were less cooperative than they would usually have been. In terms of child protection, we do know, based on our prior research on children in emergencies, though we didn't have any research quite for an emergency quite like this, that violence and vulnerability increased for children during periods of greater stress. During the Depression of 2007 to 2009, there was an increase in child head trauma from physical abuse. During the Ebola epidemic, following school closures, rates of child labor, neglect, sexual abuse, and adolescent pregnancy spiked, and many children never returned to school. There's also disruption in the response services that make children even more vulnerable. We asked parents how they responded to their children's behavior during COVID-19, and we were very pleased that a lot of parents reported that they talked to and reasoned with their children more, that they hugged their children more. But then we also had just under 2/3 of them shouting more, just over half threatening more, and just under a half using timeout more. 1/4 reported that they spanked their children more, and 1/5 reported that they passed the child on to someone else to manage the child. When we looked at reports of abuse to child protection agencies, we had some information from the Children's Authority of Trinidad and Tobago. They reported increases in children lacking care and supervision, children being emotionally abused, and children in need of supervision. Private pediatricians in Jamaica actually made a statement to the newspapers that they were seeing an increase in child sexual abuse in hospitals in one specific region of the country. And they actually made it public because they wanted the wider community to be aware that this was happening and to protect children more. However, the Office of the Children's Advocate and our Children's Registry actually reported a decrease in the number of reports of child abuse. And this was indicative of children's limited access, schools, churches, and other community services remain an important contact point for children who are victims of abuse and facilitate their reporting. With these being closed, the number of reports of child abuse reduced. Now look at the impact of children's development and education. When we look at the worldwide trends of the impact on education, we see that in the Caribbean, which is the orange line at the top, up to January 2021, there were 29 weeks of school closure. The average was 22, the world average. So the Caribbean was the region of the world that had had the most prolonged school closures up to that time. I wanted to indicate here that we were not starting off on a good footing in the Caribbean in terms of education. This is the World Bank Human Capital Index project, and what it shows is that children have roughly somewhere between 12 and 13 years of schooling up to the age of 18 years. However, the learning adjusted years, which measures the actual years of schooling that they get within that period of schooling, is much less. So our children were starting off already with a learning deficit based on the actual years of schooling compared to the time spent in school. So this slide looked at children's access to educational material by educational level. And at the pre-primary level, we can see that children in the homes were primarily using their books and materials in the home and their school books, and only to a small proportion. Children at primary level were accessing books and materials in the home much more, and they were utilizing their school books much more, and web-based programs were very low. Please remember that this was between the very early months of the pandemic. The Jamaican Ministry of Education adapted very, very well, and later on, a number of children were able to access all the web-based programs that they had put on, and also radio and television programs. As we can see, though, the secondary school children were still not accessing educational material that much. We looked at the frequency with which children got materials from their schools, and some of the teachers became very, very creative. Some of our teachers printed materials, left them at schools. Some teachers got on motorbikes and delivered materials to children in communities. Some teachers developed a community notice board. They painted a wall in the center of the community black and left work for children on the board, the created blackboard, and children would come in and write, take off their lessons, and then go home and do the lessons. But what we found was that the main source of receiving information from schools was WhatsApp. 70 to 85% of children at primary and secondary level were receiving educational information from schools via WhatsApp. You can see here that the main focus was primary and secondary level children in terms of schools providing them with support. Pre-primary children were not the focus. Because so many children were attempting to access the internet, we looked at their access. And primarily, children were accessing the internet using a smartphone and primarily using WhatsApp. Desktops were very few. Tablets, we were surprised what proportion of children were accessing the internet using a tablet. It was over 40%. And in fact, 68% of parents reported that the children had a personal tablet. But if you notice, there's a disparity between the proportion of children who have a tablet and the proportion that were able to access the internet, because of course this comes at a cost. 3% of children had tablets from a government-sponsored program that had actually started before the pandemic, and it was the program to provide tablets for children in school. The impact of school closures, this led to disruption in schedules, limited access to socialization with their peers, reduced opportunities for development, education, and learning, with long-term consequences, particularly for the children in the preschool years where brain development is maximal at this period. There was reduced access to extracurricular activities, so there were reduced opportunities for releasing stress and anxiety. There was increased likelihood of cyberbullying and cyberstalking because of increased access to the internet. And inequity in access to education worsened, with the lower socioeconomic groups being most affected. It was often the end of school for older children. Children who were at the last 2 years of school enter the workforce. They enter the workforce less prepared and therefore were more likely to be victims of economic abuse. And these are some pictures that show inequity in access to education. So here's a little boy on the left with his smartphone doing his work. The dog even is interested. And here on the right is another little boy during the school hours working. The Ministry of Education reported that they had lost contact with 30% of the school population. So parental health, parental health worsened a bit between mental health, between pre-COVID and post-COVID periods. And what we also noticed was that parental responsibility changed. So pre-COVID, mothers were responsible primarily for childcare. Certainly they were responsible in excess pre-COVID at 57%, but during COVID, this shot up greater to 70%. Parental mental health, parents wanted support to teach their children at home and more financial support. The main impact was our economic impact. Parents reported great difficulty paying bills and providing goods for children during the COVID period. The average share of income lost was 44%. I'm going to pass over our especially vulnerable children and just end. So in the end, we had a lot of negatives with COVID-19, but we had some positives. We learned to value our own country and health and systems more. There were closer family ties. Parents were spending more time with their children and understanding their children's educational and developmental needs more. We learned new ways to do mass education. We reimagined healthcare and education. Some new jobs emerged as some diminished. And for a long time, children probably won't say that they hate school. Thank you so much for listening.
Maureen, that was absolutely fascinating, really interesting presentation, and so many things that we connect with also. It's a really shared experience for many people across the world. I can see some of the things that are affecting my grandchildren in that account of West Indies. Finally, can we move on to Professor Kandylaki in Greece to talk to us about social work challenges in a broad way and to bring us really up to a broad conclusion. Thank you.
Okay, well, I would like to thank you all very much for inviting me to this particularly interesting day conference. And I would personally like to thank also Mary Baginsky, who I have happened to have met her before in other conferences, and also Malcolm Payne for his contribution to the way that we are teaching and examining theory in Greece as well. It's been a great pleasure to meet you in contact, even virtually, and I would like to thank you very much for that. Well, my presentation will be focusing on COVID-19 pandemic and the challenges for social work in Greece, viewing it from a critical perspective. Now, allow me to pay a small tribute to the kind of disasters that we've been going through apart from COVID or simultaneously with COVID, and which is actually the war in Ukraine. This is another global disaster, it appears, that brings up again the issue of refugees. I was hearing the news that it is about one person per second that becomes refugee nowadays with the war in Ukraine, and also that there are about 3 million refugees currently, 1.5 of which are children. And I think we have to consider this situation within and put it within the framework of COVID and how the one implements to the other. I'm only saying that because we have to take into consideration that disasters never finish, and we have to cope with many disasters, multiple disasters, at the same time and in a global level currently. So, as I said, the aim of my presentation is actually to discuss and reflect on the emerging challenges for social work in Greece during the pandemic. And I will actually refer to a qualitative survey, a piece of research that took place in the early phase of this pandemic and during the first lockdown period in Greece. And I will explain why I think this is essential to still keep on that information, because actually that was the first time that we have been faced with this new threatening situation, which was actually a deadly situation as we were facing it, and social work as a frontline profession, they had to actually automatically change and apply into a different way their services. Now, this qualitative questionnaire was actually based on open questions, so it was asking for their reflection on their experience, best practice examples, their feelings and their perspectives and challenges, etc. And I will present to you a few of those issues that have been revealed from that work. Another important aspect of my presentation is actually that we need to examine the pandemic period through the various perspectives that have emerged and through the various periods, I would say, or phases of the pandemic during these 2 years of the disaster. It has provided, we definitely can say that it was a global, it caused global and local challenges at the same time, both on a health and social policies level, on a European level. So there were actually disaster responses to the disaster mainly on a European level, although it wasn't. We are not still in a situation where we could perhaps talk about common social policy practices on a European level, but there has been much more closer interrelation and influence from the one country to the other than it used to be before. Another important element is that critical social work and human and social rights, they became even more importantly in the forefront during this pandemic period, as social workers from day one, they were actually feeling a lot stressed about what would happen, particularly for people who live in very vulnerable conditions. So they were bringing into the surface all the issues of social justice and inequalities, and put an alert on the importance to pay attention to the people who live in more vulnerable situations. And then this, as every disaster, more particularly COVID-19 pandemic, caused shared traumas and resilience to both service users and professionals in the field. Now, there have been, however, some other important aspects, which is an increasing of solidarity and co-working during this period, which was a source of resilience for professionals, and it helped a lot to empowering people and being empowered themselves as well during the pandemic, and also the kind of reflection on prejudices and stereotypes, and how the way that we perceived prejudices and stereotypes can be in a way re-examined during and after this experience of the pandemic. And I will explain to that. I will explain this a little bit later. So from the very first moment, there have been a number of webinars taking place, both locally in Greece and internationally, that were accessible to the Greek professionals. And actually this technology, the use of the technology and the internet helped us a lot to communicate internationally a lot more than we used to do before. So all these webinars, they were focusing on consciousness raising. I would like to stress one aspect, however, which I think has in a way influenced the situation we have come up 2 years later, and this is actually the emphasis on putting Michel Foucault's work to the forefront, and on talking about the politicization of medicine and the medicalization of politics during the COVID period. This has been a discourse that was very much within the webinars that took place in Greece, because the experts, medical experts, they were very frequently on the TV explaining about the virus and giving statistics day after day and giving suggestions, etc. And they were actually, in a way, consultants to the government in terms of taking the stricter measures and lockdown and loosening the measures later on. And this actually brought up this debate of politicization of medicine and medicalization of politics. Now, this, however, had a bad influence. Of course, it wasn't the only one, but it had a significant influence into developing a kind of different perspective about the vaccination issue. Allow me to say here that in Greece, although the vaccines have been available from the very first day that they were on, and they were totally free, of course, it is now only 70% of people that have been fully vaccinated, and it's only 51% that they have had 3 doses of the vaccine. And of course, there are many reasons that may inhibit people from being restricted to vaccination, which may be political, they might be cultural, they might be theological, or kind of associated with the beliefs, etc. But they all lead to a kind of conspiracy theory and a denial of vaccination. And among that, there's also this perspective of medicalization of politics or politicalization of medicine. But let's have a look at the social work in the front line in the disasters. And as we said, of course, they are in the front line in the refugee crisis as well. And we have been through that refugee crisis in Greece, particularly during the 2014 and 15. So we have had a very recent experience of dealing with such big global crisis. And then resilience and flexibility and belief in social change have been the resources that helped professionals dealing with the crisis, with the previous crisis and the crisis during the pandemic. Also, kind of empowering perspectives by working on virtual group work, as for example, working with virtual group work and individual work, of course, but also group work with refugees and accompanied children and women refugees with the use of interpreters. And this was happening simultaneously in a group work, particularly in hostels in the mainland. There have also been significant changes to social work education, although there have been periods that that students could not be working on placement. There was a lot of effort in terms of online lessons to make them even more interactive than we used to do in class, and increase their creativity and the group work between them and also within the webinar online class. Other challenges that we have been facing in Greece, as I said before, are kind of emerging throughout the various periods. And allow me to say that we can actually split these 2 years of COVID-19 pandemic, split it in various periods. For example, the first lockdown period, which was in early March 2020, very soon, just the day before the first case was introduced in Greece, was identified in Greece, and that lasted for about 5 weeks, and it was and then it was followed by a summer period where the measures were loosened a lot. Then it was a second lockdown period that followed in the winter of 2020, which again was followed by stricter measures in January 2021, and the third lockdown period during early springtime, just before vaccination started. Since vaccination started, we have been through ups and downs with stricter and loosening measures. And this is actually a going on situation where the main perspective nowadays is how we can even influence most people to get to be vaccinated. The kind of frontline social work emergencies and challenges, as it appears, from the very early days was, as I said, to bring up to the surface these values of social justice and dealing with inequalities, but also, and by this they became advocates who ring the alarm for those who are living in the most vulnerable situations, such as the Roma communities in the local authorities, the assistance at home projects, helping the elderly and the disabled who lived in these social distancing situations, the homeless people, particularly in the city of Athens, in the capital city of Athens, and there was a very quick response on behalf of the municipality, and that during this lockdown period, 2 new homeless centers were introduced in order to shelter homeless people and take them away from the street due to the fear of COVID-19 situation. Another huge problem was the issue regarding the refugees in the camps and the hostels. Allow me to say that during 2020 and the beginning of the pandemic, there were some hugely populated hotspots, especially in the islands. And one of those most well-known examples was Moria in Lesbos, which at the time they had 25,000 people. And that was a great fear that of what would happen to those camps during the pandemic. Then there was an alert about family violence and abuse, and how can we preserve women's and children's rights during a period of social distancing. The increasing risk for children and adolescents to get addicted to internet, and the cyber addiction was another fear. And also the fear of the increase in unemployment and losing benefits during this period was also another alert. But furthermore, and that started from the second lockdown period, was the fear of losing freedom, and whether this situation of lockdown actually, in a way, would lead us to a kind of losing our human rights and the right of freedom, etc. And the fear of an anxiety about what would the next day look like, and we're still looking for this next day. Now we have a very soon realized, and when I say we, I mean social work professionals in Greece, that we've been faced with another shared fears and traumas which are shared with our service users, and we need to find resources for resilience and solidarity and support. And those fears is the fear of death and the fear of the disease, more in the beginning than later on, although the reality is exactly reverse, that the very first period of the COVID-19 era in the Greek environment had less deaths and less ill people within the national health system, while later on these numbers increased significantly, but the fear in the beginning was much more than it was later on in terms of death and disease. Then it was a personal fear and traumas which were frequently shared between professionals and service users in terms of how do we deal with grief, which is in a very different situation, but taking into consideration the cultural aspects of grief in Greece, which were actually denied during the social distancing period, that made the situation being much more difficult. And also there was an evident need for counseling and more need to communicate both between service users and professionals, but also between professionals which needed opportunities for supervision. Let me go very quickly on the use of technology and the advantages that have been coming up. There was a quick digitalization for the public service and educational services, that they were quickly digitalized, although there was a big inhibitance before that, and teleworking, etc. I would like to refer to this example that Professor Maureen said before about teachers delivering work into the houses of students in South Africa. In Greece, we have got some cases where social workers would do the same, and one of these actually revealing signs about child sexual abuse in that child, and it was a case conference that took place afterwards. Now let me go on with all this. The previous experiences of working with crisis have been very useful for social workers to dealing with the crisis emerging due to the pandemic. Creativity, solidarity, and group work with Zoom was one of the advantages of this period, and it was very important that we go on and do a critical reflection on the knowledge and experience that has been gained throughout these 2 years. One of the important aspects was that family violence and child sexual abuse have been more seriously considered, and there have been further cases that have been revealed and recently. And also, we have been dealing with other disasters which coexisted at the same time with the pandemic, which were earthquakes and big fires which have occurred. The webinars have been very important into actually encouraging and empowering professionals. The refugee issues, there have been changes there. As I said, from 25,000 people that were in Lesbos in the early 2020, there are 28,000 still remaining in the island, which is a big change, although there's still a long way to go on. And another advantage is the closer cooperation between professionals and academics, both within the Greek environment and internationally, and the critical questioning, the continuous critical questioning on what we are observing and how we can deal with this. And finally, raising awareness of professionals and networking and co-working and the critical perspectives on, along with counseling skills that need to further develop within social work education, is another important aspect, as well as continuously promoting human and social rights and social cohesion. Well, thank you very much, and I'm quite happy to respond to any questions that you might have.
Agapi, that was a fascinating and thoughtful contribution, bringing us to thinking about the broad issues for the future of the social work profession arising from this particular crisis. And you've also pointed to the fact that we're moving into many other crises too. Rick, I don't see masses of contributions in the Q&A that I can see. Have you got points that you need to pick out of the chat and the Q&A?
So there's a couple of questions for Rachelle, just that have been put in the Q&A. There's one question from Chris, who is a social worker working in London with people with spectrum disability, including deaf people, and he is also studying at Kingston. So the question was, how did this work in terms of those virtual services? How did that work for people who couldn't access telephone calls, such as people in the deaf community, deaf people in Canada? So that's a really good question. And then the other one is about whether, from Shalina Wilson, who asked whether the additional planning that was needed around collaboration, whether that didn't have maybe some beneficial knock-on effects in terms of, improving systems more generally. So a couple of questions for you, Rachelle.
Sure. I'm happy to answer, and maybe I'll start with the second question first. And I completely agree that having some kind of formal planning around collaboration has some benefits that have not been capitalized upon in many of these teams, particularly with case consultations. And for somebody, myself, who's really interested in building capacity around mental health care, I think there's a lot that needs to be done in order to enhance the formal aspect of planning with collaboration. The challenge that lies ahead are twofold, I would say. First is thinking of the organizational context of these teams and how scheduling has been done in order to facilitate the attendance of physicians primarily. We know prior to COVID-19 that it has been challenging to get the combination of different providers that you would want at some of these case consultations in these community teams together. So that's one thing to think about. The second thing to think about is around the relational component. We know from research, even prior to the switch to virtual care, that for teams, even teams who had those formal meetings and came together around formal case consultations, the glue and the relational aspect really formed and was enhanced in those informal moments between meetings, again, in the hallways. So even with those formal planning, there's benefits, but thinking about how are we going to enhance, maintain the relational component, because the relational component is what creates trust in these teams, and that trust is what facilitates sharing when you're having struggling moments with patient care, where you feel more comfortable reaching out when you may not know how to approach a particular situation. So that trusting relationship is really, really important. I could go on about that for a long time, but I'll leave that there. In terms of the first question around who is benefiting from access and who is not benefiting from access, that's a really, really good question. And the example of the deaf community is a really good question. I don't have specifics around that particular population, but what I do know is that virtual care in Ontario, we do know that it responded. There's been disability rights activists who have been calling for better access for a long time, so it has met the needs of some populations, but we also know that virtual care has been leaving some people behind, and so it'd be really interesting to hear from people in the deaf community in Ontario of how that has been. We do know from our research that there has been challenges with homeless populations getting access to primary care in Ontario, and that some teams have even, and not just homeless populations, that people in communities with poor Wi-Fi bandwidth, some communities where there's been high levels of low socioeconomic status, and some teams, for example, early in the pandemic, sent tablets out to certain patients before their appointments to facilitate those types of interactions. And only to highlight that there are, varying experiences with access that we need to know more about in order to make better recommendations going forward. So excellent question about the deaf community.
Thank you very much, Rachelle. That was really informative. And looking now just for a couple of questions for Professor Samms-Vaughan. So I can see that I've just lost them. Yeah, so Shalina Wilson had a couple of questions for you. One of them was about severe illnesses that children were experiencing during the pandemic. You mentioned multi-systems inflammatory syndrome. Were there any other serious illnesses that children were experiencing that came to light during the pandemic? And then the other question is about tourism and whether changes to tourism had an impact and how that's being handled and managed.
Yeah, so the multiple system inflammatory disorder was the real condition that brought children into hospital for admission. Most other children did not need to be admitted, but these children have had quite severe illnesses. And this is a population that was not being vaccinated later on. So we've continued to see these cases in children. But other than that, I mean, we had the regular childhood illnesses that would come in that were severe, that came into hospital. But other than that, we didn't see any other concerns about COVID-19 itself. So tourism is a major income earner for many countries in the Caribbean. Not so much countries like Trinidad and Tobago, but many countries in the Caribbean, including Jamaica. And so the government responded very, very rapidly to that by creating a tourism corridor and ensuring that tourism workers were among the early ones who got vaccinated, and that protocols for hotels were developed very, very early. The government really jumped on that very, very quickly. But we still saw falls in tourism, and then the hotels now started encouraging locals to come because we couldn't travel, and so locals tended to fill a bit of the gap. But our tourism industry has really bounced right back, and we're really happy about that because of the employment. But it also shows to us the importance of diversification of our economy.
Thank you very much. Thank you. That's really helpful. Final question then to the last speaker about Greece. So Yanis Vlasis was commenting on the recent Me Too movement in Greece and the increase in domestic abuse during the pandemic, something that we've also experienced in this country. Is the state going to rethink domestic abuse policies and regulations? And then I also had a question about an announcement by the Greek government that same-sex couples will be able to foster children, and whether social workers, were going to be able to promote that and be on board with that. So, these will be the final questions for the plenary session. Agapi?
Yeah, well, thank you very much for this question, because I was actually going very quickly during the ending of my presentation, and I didn't mention this very important Me Too movement which took place in Greece during the pandemic period, particularly since last year, following the presentation of, the disclosure of on behalf of Maria Beccatoru, an Olympic champion, about her own experiences. I think, yes, I would like to say that an important change has been that we have now started facing the situation of domestic violence and child sexual abuse in Greece as an issue of power and as an issue of exploitation, rather than an issue which is linked with kind of psychological disturbances on behalf of the offender. And this has been a big change. And I think this influences the way that professionals have started working on the perspective. And I encounter this as a positive aspect. Following that, the situation, there have been 14 cases of femicides that came up to the forefront during the last year in Greece. And there has been a big discussion about femicide, whether that's the proper term that should be used or not. And is the pandemic that caused all this domestic violence? And of course, the answer is that it's the pandemic that actually put the focus on domestic violence and brought cases of femicide to the forefront. Not that they didn't happen before, but they were actually neglected in the way that they were being seen. So I'm more hopeful on the way that that professionals can work from now on. And as far as I know, there are new policies that are about to be introduced in regards to domestic violence. And in regards to domestic violence. Now, regarding the second question about how social workers can support same-sex couples to promote foster care and adoption, well, it is a reality that social workers has been part of Greek society, which is reserved in certain cases and has got some cultural dependencies on the Greek Orthodox beliefs. There are people that may resent into working towards that situation, but I think that there has been a great change into that, and I can consider it in regards to the students, for example, which are the social workers to be, which are very much interested into that area of Loatki families and same-sex couples fostering children, etc. And we work a lot on that in the university. So hopefully there will be a future change on that.
Agapi, thank you. Well, this has been a fascinating conference again, and covered a huge range of topics. Can I say thank you very much to all of the speakers for their amazing contributions. And one of the things that strikes me most about it is how much we share even in these very diverse circumstances that you've all been talking about. Thank you very much for that. Agapi said, disasters never finish. And she then went on to say, well, this means that all the time we are dealing with multiple disasters. We are going to be continuing to deal with disasters as social workers, and it's something that social work hasn't concentrated on. That's something that's done in another part of the society and another part of government. So we have to deal with both the short-term consequences of these disasters that we face and the long-term consequences. But what social work contributes most is, first of all, its focus on the social and on the importance of solidarity among us all. And we contribute also the importance of the people who are the poorest, the most vulnerable, children, older people, and our work with them continues in the way in which we try to help them every day. But we have to think also about the way in which we contribute to their response to disasters and difficulties. And we have to be aware, as several of our speakers have said, how the service users that we work with are among the most discriminated against, oppressed, unconsidered, unthought of, unfelt for people in our world. And social work, because of its emphasis on the social, concentrates on our solidarity with them and doing something practical about that solidarity, both in our practice and in our research. Our research, you have shown today, is how we have tried to respond and do something for the people who most need our help. I know that as we move on to the workshops this afternoon, that people will be talking about how we're doing that locally in Kingston. But thank you for this global perspective about what social work is doing. It's a small profession, but its message is a really important one. The social is important. The people who are most oppressed are important, and we must respond to them and do what we can in every way to help them. Thank you for participating, and thank you for making your contributions.